Well, welcome everybody. My name is Trish. I'm with the Office of Statewide Health Planning and Development, Healthcare Workforce Development Division. On behalf of OSHPD, I'd like to welcome you to today's webinar. Please be advised that today's webinar will be recorded for use for future presentations.
Great.
1 second. As you can see on your screen, there's a few communication tools available to assist you with alerting someone that you have a comment or a question. If you have a question, you can click the raise hand icon in the upper left-hand corner, which will alert myself, Alan, or the speaker, who is Tom Bodenheimer, and your question or comment will be addressed. You can also send a note, and that icon next to the raise hand icon, and that way you can send a note directly to the speaker or myself, or if you can't hear, you can let us know of that also. Please, we actually are going to keep all the mics open so you guys can interact with the speaker. As he asks questions, you are open to respond and respond back to his questions. But if it does get too loud, I will have to mute those ones that have really loud background, so I'm just letting you know that. Just you can unmute yourself to ask that question also.
Great.
I'm going to go ahead and turn it over to Alan to introduce the speaker. Go ahead, Alan.
Thank you, Trish. Welcome to the webinar on team-based primary care by Dr. Thomas Bodenheimer. This webinar is being offered by the San Francisco Community Clinic Consortium and the California Statewide AHEC program in partnership with the Office of Statewide Health Planning and Development, which is designated as the California Primary Care Office. Funds for this webinar were provided by the U.S. Department of Health and Human Services, HRSA, Health Resources and Services Administration, with American Recovery and Reinvestment Act funding for a National Health Service Corps and State Loan Repayment Program Retention and Evaluation Activities Initiative. Dr. Thomas Bodenheimer, MD, MPH, is Professor of Family and Community Medicine at the University of California, San Francisco, Center for Excellence in Primary Care. He trained at Harvard Medical School and did an internal medicine residency at UCSF. He worked for 32 years as a primary care physician in San Francisco, both in community health centers and in private practice. He has written many articles for such journals as the New England Journal of Medicine, JAMA, and Health Affairs, and is co-author of a textbook on health policy and a book on redesigning primary care. His major interest is in solving the problems facing primary care in the United States. Dr. Bodenheimer.
Thank you, everybody, and good afternoon. It's afternoon.
Mm-hmm.
So,
good afternoon.
We're going to talk about teams. Now, what I'd really appreciate is, number one, people asking me questions when you have questions. Don't wait for the end. The more questions, the better. But I'm also going to ask you some questions. You don't have to answer them, but if you want to answer them, you can either do the raising your hand thing or send me a note. Or just talk.
Okay.
So, everyone thinks that teams are just a natural thing that we need in healthcare, and they're just going to happen, and it's not a big deal. Well, it is a huge deal. So everyone will say, yes, we need teams. We can't do this without teams. Doctors by themselves cannot take care of all the patients that need to be taken care of. We have to have teams. But then you look around to primary care practices, what you see is either no teams or teams that aren't working very well. However, there are some examples of incredibly wonderful teams that are making a huge difference in terms of the clinic working well and patients getting better care. So the question is, how do we move from the situation of no teams or not very good teams to a situation where teams are really functioning well. So this first question of why do we need teams is important, because if there's no good reason to have teams, in a way it's a lot easier not to have a team. So here's some examples of some pictures of teams, hopefully. Now this team we're going to come back to in a little while. The interesting thing about this team is that this is a team of two. We're going to be talking about teams of two in a few minutes. Now, the other thing that's interesting about this team is, and that's one reason why we do need teams, is that without a team, this little dog could not have gotten where he or she needs to go. And I think one of the things is that teams really allow us to do things that we can't do without teams. Now, creating teams is not simple, as I said before. Very frequently, if you, on average, if you have 5 people and you put them in a room together, one of them is going to maybe be a difficult personality or not liking to interact with other people or be very individualistic and make decisions by themselves. So this is not a 5-person team, it's a 4-person team with a not so uncommon person who's not playing by the rules. Happens a lot.
Huh.
So the larger a team is, the more time it takes to communicate. So if you're taking care of 1,200 patients and you're a physician or a nurse practitioner or physician assistant and you're taking care of them by yourself, you're not going to be able to do a very good job because it's too much work, but you won't have to spend a lot of time communicating with other people.
Right.
It's all you. So the larger the team, the more time it takes to communicate about each patient with other team members who are interacting with that patient. So it takes time and energy to have a team.
Right.
One person who's uncooperative can ruin a team, and we've seen that so often. And so sometimes the easiest team is a team of one person. So that really gets back to why do we need teams? This little cartoon says, yes, I work well with others, just not these others. So people have to work together to be on a team. So what I'm trying to make clear is there has to be a reason to have teams, because having teams is not so simple. So one of the problems that happens to many, many community clinics is that we don't have access to our patients when our patients want to come and be seen.
Right.
So let me ask this question to, well, Joanna, you're in a community clinic?
Yes, I am. Mhm.
Do people have access when they need it easily or not all the time?
Not all the time, although we do have a triage team where when patients come in, regardless of the situation, they get to be seen. However, those waiting lists sometimes can be 3 or 4 hours before someone can be seen. So people eventually get tired and they leave, or they end up in the emergency room.
Yeah, so it's not ideal access.
Right, exactly.
Very few clinics have ideal access, and the reason for that is that to have ideal access, your capacity to provide care has to be the same as as the demand for care.
Exactly.
So demand is the number of appointments that patients want. Now this is like, there are other ways to get care besides appointments, but let's keep this simple. Demand would be the number of appointments people want. Capacity is the number of appointment slots you offer to patients. So if you have, say, one doctor and one nurse practitioner, and they together can see 40 patients a day, your capacity is 40 patients a day. And if you have a demand of people if you have 60 people who want to be seen that day, then your demand is greater than your capacity.
Right.
And if that's the case, you're not going to have great access.
Right.
So in most federally qualified health centers, community clinics, and private practices, the demand is greater than the capacity. So for me, the most important reason why we need teams is to add capacity, to be able to see more patients without necessarily having more clinicians. By clinician, I mean doctor, nurse practitioner, or physician assistant. Teams need to add capacity. I'm actually going to make the blanket statement that if a team does not add capacity to see more patients without more clinicians, that team may not be worth having. Adding capacity is crucial. So, can we add capacity by having more doctors? Well, there's a huge shortage of doctors for primary care.
Right.
Most community clinics can't find all the doctors that they feel like they need. So adding capacity by having more doctors is a very nice idea, but often doesn't happen. Having more nurse practitioners helps a lot, but there are not enough of them to go around. Physician assistants, the same thing.
Yeah,
so even though it would be nice to increase capacity by adding these clinicians, there's a shortage of those clinicians compared to the demand that we need. So we have to figure out a different way to add capacity. So if you look at a projection of the United States capacity demand situation, the demand is going up, 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 up. Population's growing, population's aging. The Affordable Care Act is making more people being able to afford getting care, and then the diabetes and obesity epidemic. So demand for primary care is just going up, 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 up. The supply, if you look at physicians, is beginning to go down because so few physicians coming out of U.S. medical schools want to go into primary care. So look at the gap in 2020 between the demand and the supply. This is just if you look at physicians. Now, what if you add nurse practitioners and physician assistants? Well, they help a lot, but for physician assistants, only about a third of them go into primary care. For nurse practitioners, it's about two-thirds. But if you add up all of the nurse practitioners, physician assistants, general internists, and family doctors going into primary care, and you project it out to 2020, the number of primary care clinicians to population is going down. So we're in huge trouble in primary care in terms of having the capacity to deal with the demand of the population, which goes back to teams. The only way we're going to succeed at having demand and capacity equal to each other is to have the teams add capacity without more doctors, nurse practitioners, and physician assistants. That's not going to happen.
Right.
So this is a huge issue because how are nurses, pharmacists, medical assistants, health educators, behavioral health people, how are all of those other team members going to really add capacity and solve this problem of access to primary care? That's what we need to do with our teams. So if you look at a different way of looking at it, which is not just to think about doctors, but to think about the demand and capacity by sharing the care with other people on the team, you can look at this red line that says capacity to provide care, and rather than that line going down, which it goes down if we're just thinking about physicians, now that line's going up because we have nurses and pharmacists and medical assistants and all sorts of other people on the team actually providing care to patients in addition to the clinicians. So we think that the problem of adult primary care shortage can be solved without necessarily having a huge number of more doctors, nurse practitioners, and PAs. Because that's the only way it's going to work. We have to do it that way. So that's why we need teams. We need teams to solve that horrible problem of lack of our ability to deal with the demand for primary care by the U.S. population. And I've been talking about sort of nationally, but each clinic has a very similar problem within itself, which is usually the demand of the patients in that clinic is greater than the capacity that clinic has to provide the care. Okay, that's the bad news. Now the good news is that there are a number of practices around the country that have solved the problem. They have big panels They have same-day access or same-week access for every patient. People don't have to wait 3 or 4 hours and get screened. They just come in and they have plenty of slots for them. But some of those slots are not clinician slots. They might be nurse slots or pharmacy slots or medical assistant, health coach slots. Other people taking care of patients, adding capacity. We call that sharing the care. And the fact is that we have seen a number of clinics do this. So if a number of clinics can do it, then every clinic can do it. So we went to a bunch of practices around the country, and we looked to see. These were all high-performing practices that were recommended by people as being really excellent practices. And we went to them and we said, what are the characteristics that are common among all these practices? And it turned out that a lot of these practices looked similar to each other. So we extracted from these similarities what we call the 10 building blocks of high-performing primary care. And these building blocks really are there in these practices. And if those practices can build their medical homes with these building blocks, then any practice could do it. It starts out with leadership, and you need to have improvement, which is driven by data. You have to empanel your patients so the clinicians know who their patients are, the teams know who their patients are, and the patient knows who their teams are. And that gets to team-based care. And we're not going to talk about all these building blocks. We could spend several hours going over each building block, but this is particularly a discussion of team-based care. Let me just ask, does anyone have any questions at this point before we kind of delve into team-based care? We're also going to talk some about population management because it's very related to team-based care. So to have teams that really add capacity and that really function well, a number of things are needed. And again, we're not going to talk about all of these, but one of the things is a culture shift. And as we know, in a lot of practices, the doctors make all the decisions and also have all the responsibility. In true team-based care, it is not a doctor who's taking care of a panel of patients. It's a team that's taking care of a panel of patients. So we're going from I, the doctor, to we, the team. The other part of the culture shift is that we're not just talking about the people who have an appointment today or tomorrow. In this culture shift, we're worried about the entire panel of patients that we're responsible for. So if you have a doctor and a medical assistant, or a nurse practitioner and a medical assistant, who have a panel of 1,200 patients, which is a typical panel size for community clinics, both of those people are responsible for the health of that panel of patients. Whether or not they come to the clinic, every single one of those 1,200 people, we want to make sure they're as healthy as possible. The other thing that was very fascinating about the high-performing practices that we visited was that they tended to have a very similar team structure. So team structure is how is the team organized. So in a way you can think of a team as having anatomy and a physiology. So the anatomy is like the structure of the team. The physiology is how does the team work together, how does it communicate with each other, and so forth. They tended to have two people, which we call a teamlet being a small team, and around several teamlets there was a larger team. So the teamlets in most places was a clinician, which could be a physician, nurse practitioner, or a physician assistant, and a medical assistant. Now in some places it was a physician and an RN. I know in California it's difficult to have RNs in primary care clinics because they're fairly expensive, but they're not as expensive in other places in the country. So the most typical teamlets were the clinician plus the medical assistant. And then around 2 or 3 teamlets, there were some other supporting people who supported, say, the 3 teamlets. Often it'd be an RN, the behavioral health professional, social worker, If you're lucky, a pharmacist, because pharmacists are incredibly helpful in a community clinic or any practice. Maybe a complex care manager, nurse, who is responsible for the very difficult, complex, high-utilizing patients on your panel. So again, one large team, but 3 small 2-person teamlets. Now, why do we think that teamlets are important? Well, the first thing is, we talked about the culture shift from I to we, from the doctor to the team. So let's look at it from the patient's point of view. Does a patient want to see a team, or does the patient want to see a doctor? Now, in our culture, most patients say, I want to see a doctor. Well, there's actually some very interesting research that was done by the California Blue Shield Foundation, in which they actually asked patients, would it be okay for you to see a team, even if it meant seeing a doctor less often? And most people said yes, as long as the people on the team know me and I know them. So it's very important to patients to know the people on the team. Well, we don't feel like asking patients to go from being taken care of by a doctor to being taken care of by a team of 8 people. That's too big a shift. Being taken care of 2 people instead of 1 person is something that I think a lot of patients would like. And in a lot of these high-performing practices, the patients just really had a wonderful relationship with the medical assistant on their teamlet, on the teamlet that was responsible for their care. In fact, a lot of people would trust the medical assistant as much as they trust the clinician. So a teamlet is better for the patient than a big, huge team. And again, if the person has, say, a mental health problem and needs to see a behavioral health professional, that person comes in. The person needs a social worker, that person comes in. But the basic relationship is between the patient and the small teamlet. Now, we're doing some studies of teamlets and teams in community health centers in San Francisco. What we found was, a lot of clinicians are very unhappy in primary care. They're stressed out, they're burned out, they're working too hard, et cetera, et cetera. So we asked them, how satisfied are you with your team's situation and how burned out are you? And what we found was that the ones who worked with the same medical assistant every day, who had a stable teamlet, were much more satisfied than the ones who worked with a different medical assistant every day. So in a lot of our clinics, we don't have stable teamlets. Different people work with different medical assistants on different days. Having a stable teamlet, working with 2 people working together all the time, is really, really helpful. So one of the things, I'm going to give some homework here. We're not going to deal with it on this webinar, but these are things which I think it's really important for different clinics to do, which is making a structure, a chart of your team structure in your clinic. So like, list all the clinicians, list all the medical assistants, which ones work with which? Do they work with the same people every day? Do they work with different people? Is it possible to set up a situation where you have the same medical assistant working with the same clinicians as much as possible? How many teams are there? Who is on which team? Is each team responsible for a defined panel of patients? So say there's a clinician and a medical assistant. Do they know who their patients are? Do their patients know who they are? That's the ideal situation. If anyone wants to say anything about a primary care clinic that they're associated with, about their team structure, please go ahead and talk. We'd love to hear from you. So here's another part of homework that I think would be really important for people in primary care clinics to do. So make a chart not only of the team structure in your clinic now, but how would you like the team structure to look in the future? Now, this is not so simple if you don't have stable teamlets. Then you have to figure out which clinician is going to work with which medical assistant, and you want to pair them up carefully. You want to make sure they get along with each other, because they're going to be working together a lot. But we feel very strongly, and the practices that we went to that are high-performing practices all had stable teamlets with larger teams around several teamlets. And that the teams were responsible for a defined panel of patients, and the patients knew them, and they knew the patients. So this is something that would be important for practices to do, to figure out their team structure. So we've talked about structure, but then there's the question of what does a team actually do, and how do we add capacity? And we call that share the care, sharing the care among the entire team. And that means that non-clinicians on the team need to take responsibility for things that don't require the level of training that doctors, nurse practitioners, and PAs have. And a lot of primary care is actually pretty algorithmic. In other words, there are practice guidelines for how you take care of things. So you really could write standing orders that empower non-clinicians to do a lot of the work to take care of those patients. And we've kind of started in working with clinics to share the care with two specific things, which are panel management and health coaching. So we wanted to talk about that. Here's another homework thing. Taking this little chart, it's called Share the Care, Who Does It Now? And these are 10 relatively routine things, but very, very important things because they deal with how well people's chronic care and preventive care are taken care of. These are things that should be done in every primary care practice. The question is, who does them? Now, most of the time when we pass out this little form, what we find is that the primary care physician, which really would be a primary care practitioner or a clinician, does almost everything. And the other people on the team are not doing any of these things, whereas all of these things are things that one could train anyone to do and could write standing orders that empower them to do them. So that's another thing that's worth doing in your clinic, is to get this little form and have everyone fill it out in terms of who does what in your clinic. And are you sharing the care, or is the clinician doing everything? Because if you're
how
not
did you
sharing,
pick? Excuse me, Tom. I just wanted to ask, how did you pick this set of tasks? And I would assume there are others.
there are probably 50 that you could pick.
Yeah.
We picked things that we feel like, number one, are very important, like making sure that every woman between 50 and 75 years old has a mammogram every 2 years.
Mm-hmm.
So we're going to talk about that, how one might share the care with mammograms in a minute, so I'll leave that one to go. Refilling high blood pressure medications. So medication refills is something that actually a lot of places do with standing orders to have the nurses do it. So if you have someone who has stable high blood pressure, who has regular appointments, and who's had lab tests when they're supposed to have them, there's no reason why you can't refill their benazepril or some one of their standard blood pressure medications. That why an RN or we think even the medical assistant could do it under standing orders. That there are some legal questions about that. So that's work that we think could be taken off the clinician's plate, because we think the clinician should be doing diagnostic work and working with more complicated patients and so forth. Performing diabetes foot exams, it's something we've trained a lot of medical assistants to do that. So these are things that are common in primary care and that we feel could be shared with other people in the practice. But you could expand this list many-fold. We just picked 10. So if you take your panel of patients, every single one of those patients needs preventive care. Everybody needs it. So panel management is making sure that every single patient on your panel has all the preventive care things that they need. So we do a lot of training of medical assistants to do panel management. And they make sure that those patients get these routine services. And a lot of them are either immunizations, or cancer screening, which is usually cervical cancer, breast cancer, or colorectal cancer. And then there's some chronic care panel management things, just making sure people with diabetes get all the lab tests they're supposed to get. So if you have standing orders, you can empower medical assistants to do panel management. And what happens is that care quality improves. So the reason it improves is not that doctors don't know how to do this. It's that doctors or nurse practitioners or PAs who have, say, 5 problems to deal with in a 15 or 20-minute visit, the routine preventive care stuff doesn't happen because there's not time to have it happen. So having someone else do it enables it to be done more often. So quite a bit of research is coming out showing that if you have someone else do the routine preventive care tasks, more patients will get those tasks than if you rely on the clinicians to do it. And we've actually calculated that you could take about 50% of everything that needs to be done with preventive care and share it with medical assistants, and it will get done. And if you train the medical assistants well and you mentor them well, it can get done well. It's another reason to have teamlets. If you have different medical assistants working with different clinicians every day, then there's no real relationship between the medical assistant and a panel of patients. So the medical assistant doesn't know the patients don't know the medical assistant, and also you're not sure which medical assistant is supposed to do what. If you're working with the same medical assistant every day, then there's some accountability, and the medical assistant knows that her job is to do this panel management work, and you'll know whether it's done or not. And the clinician and the medical assistant can also talk a lot about particular issues regarding the panel management because they're sitting right next to each other working together every day. So sharing the care through panel management, through preventive care, can enormously increase capacity and enable you to see more patients without more clinician time. So here's an example, mammograms. So the old way is that the clinician does everything, and what happens is that a lot of times it doesn't happen. The other thing that happens is, and we've seen this so often, and there's research that backs this up, many women who get a mammogram that's normal are never told that their mammogram was normal. Now, my feeling is that's wrong. If someone is doing a test, they need to know. Women worry about mammograms. They need to know whether it's normal or abnormal. So here's a different way of doing it, using your teamlet. Medical assistant checks a registry every month, and a registry, most practices now have registries. It'll list all your patients and all your women between 50 and 75 years old whom the U.S. Preventive Services Task Force says should have a mammogram every 2 years. It'll be on the registry whether that person is overdue for the mammogram or not. If they're overdue, the MA contacts the patient and tries to get them to come do the mammogram. When the result comes, it doesn't come to the clinician, it comes to the medical assistant. Again, the clinicians are overburdened by inboxes that have hundreds and hundreds of things on them, and they're going home and at 11 o'clock at night opening up their electronic medical record and trying to deal with all these inbox messages. Well, someone else could take care of this. So if the result's normal, the medical assistant notifies the patient, and there's much better chance that the patient will actually find out. If it's abnormal, then the clinician's involved. So for most people, the clinician's not involved. Women who are 40 to 50, where it's sort of a choice for them if they should have a mammogram or not, or if they're high risk, they should have a mammogram, then the clinician might be involved with those patients for discussion. Similar thing with colorectal cancer screening, can be done really by the medical assistant. You have to have standing orders. The medical assistant has to have time to do it, has to have training, and it's best done on the teamlet where the medical assistant can consult with the clinician if necessary. So very different way to do, I just went backwards, a very different way to do routine preventive care, and it works really well on some of these clinics that are doing it that way. So other people on your panel, but not all of the people on your panel, are going to have a chronic disease. Probably about half will have a chronic disease. And those people need health coaching. So health coaching really means helping people to understand their chronic condition, helping them with behavior change action plans to engage in healthier behaviors, making sure they understand their medications, working with them on medication adherence, because medication adherence is very poor with chronic disease. People don't take their meds regularly. And we've trained many medical assistants to be health coaches. We've trained RNs to be health coaches. And we've trained patients to be health coaches for other patients. So we had about 30 low-income patients with diabetes. We trained them for 36 hours. Then we paired them up with other patients with poorly controlled diabetes, and they did health coaching for those patients. And we did a randomized controlled trial, and the patients who had a peer coach, another patient with diabetes as their coach, had statistically improved hemoglobin A1Cs compared to usual care. So health coaching, even done by other trained patients, can work. And it also increases capacity, because most of the time it takes to take care of someone with diabetes or hypertension or high cholesterol is really working with patients to make sure they understand their disease, working with them on behavior change and medication adherence. You don't need a doctor, a nurse practitioner, or a PA to do that. You can train anyone on your team to do that as long as they have time to do it. So that can also increase your capacity, because a lot less time is going into those activities by the clinicians, who can then use the time for more patients. So sharing the care through health coaching with chronic disease. So let's look at another example. High blood pressure. Clinician sees the blood pressure, may change the meds, refill the meds, makes follow-up appointments. No one talks to the patient about med adherence. It's just amazing how many doctors, if someone has a blood pressure that's not in control, how many doctors give them another med and don't ask them and really explore with them, are they taking the meds that are already being prescribed? And often the blood pressure is not adequately controlled because the clinician doesn't have time to deal with blood pressure after they've dealt with 4 other problems that the patient has. So what's a different way to do this? It might provide better care, increase capacity because someone else is doing this instead of the clinician. So checking the registry every month, seeing whose blood pressure is out of control and hasn't been seen on time, contacting those people. Now the best people to be involved in this are pharmacists or RNs, though health coaches can actually do quite a bit. Health coach can do the education, medication adherence, lifestyle change. It's best to teach the patient how to be involved in their blood pressure care by doing home blood pressure monitoring. If the blood pressure is elevated and the patient is taking their meds, then maybe they need a pharmacist or an RN to intensify their meds using standing orders. You only need, in a few cases, to consult with a clinician, because this is really pretty basic kind of stuff. Many people can learn how to do it. Health coach can follow up with the patient by phone or email. Again, clinician barely involved. So high blood pressure is probably the most common chronic condition in the United States. Only 50% of people with high blood pressure have their blood pressure controlled. In the Kaiser system in Northern California, 85% of people with high blood pressure are controlled. Why is that? Because they've said, we're going to have the pharmacists take care of people with high blood pressure because the physicians have too many other things to do. It's working great. So sharing the care can increase capacity to see more patients and provide better care. Now, we talked a little bit earlier about the whole relationship between the patient and the clinician. And that relationship is changed with a team-based care, because the patient is now being taken care of by a team rather than just by one person. And again, what I mentioned before is that this survey of patients said that they're willing to do that as long as the team knows them and they know the team, which is, again, why a small team makes the most sense to preserve that relationship. So in Clinica Family Health Services in Colorado, every patient is empaneled to a teamlet, which is a clinician, could be a nurse practitioner, physician assistant, or a doctor. They get a little business card the business card has the name not only of their clinician, but also of their medical assistant. And they get to know their medical assistant, the medical assistant gets to know them. So you do preserve the relationship. You don't fracture it by having team-based care. So again, this is what we think is the best team structure to help preserve the relationship between the patient and the team and not have too many people involved in taking care of a patient. So this gets back to the dogs. This is a teamlet. This is another teamlet. So here we have a family medicine resident and a health coach, Liz, who's in the middle, working with a patient with diabetes. And most of the things, they happen to be meeting together, but most of the time, many more visits with Liz, the health coach, than with the doctor, because all the doctor needs to do is change meds. That's the easy part. Liz has the hard part, which is, and Liz is a medical assistant, she has to work with the patient on, what is diabetes, what are the goals, how do I reach the goals, what kind of behavior change do I need, am I able to do it, what are my medications, do I understand my medications, and am I taking them, and if I'm not taking them, what can we do to barriers to taking the meds. So Liz has the hard work. So remember we talked about panel management and making sure that everyone has their chronic and preventive care needs taken care of. So again, part of this survey was, does the doctor feel confident that the medical assistant will actually take care of these preventive care tasks that really need to be done or are critically important? And what we found was that the big blue lines, dark blue lines, are people who work in teamlet, the same MA and the same clinician working together. And there the clinician had much more confidence that the MA would actually do these tasks than people who didn't have a team at all. Same thing with immunizations, cancer screenings, and diabetes care. Working with a teamlet greatly increases the confidence of the clinician that the medical assistant will really take care of things. And if the clinician, especially doctors, if doctors are not confident that someone else is going to do something, they're not going to let go and let them do it. So we're coming toward the end of this presentation. Sharing the care means that non-clinicians assume responsibility for care. Two great examples of that are panel management and health coaching. There are actually many other examples also. So take acute care, for example. So say a young woman with a urinary tract infection that when you take the history, it's not complicated. It's pretty clear that it's a basic bladder infection. There's no reason in the world why a registered nurse couldn't take care of that patient completely. There are studies that show that you don't need to see the patient, you don't need to do a urinalysis, you don't need to do a urine culture. If you take a good history and there are no red flags or complications, then you can just order the person antibiotics over the phone. So, and then low back pain, some wonderful studies that show that physical therapists can take care of low back pain better than doctors. So why not have everyone with low back pain see physical therapists first, and then only if there's complications, see the doctor? So physical therapy could be a very helpful person to have on a team. Now, most places don't have a physical therapist on their team, but it's just an example of how non-clinicians can add so much capacity and quality to primary care. So many, many things can be done by non-clinicians. Then we get to the whole question of payment. This is a problem. So doctors, nurse practitioners, and physician assistants get paid when they see a patient. A nurse often doesn't get paid. Pharmacist often doesn't get paid. Medical assistant who might do a health coaching visit with someone with diabetes or hypertension won't get paid. So this is a big problem because we all need to survive financially, whether we're a community clinic or a private practice or whatever. So we really need payment reform to do this. But there are a number of places that have succeeded in doing this health coaching and panel management work, even under our current payment system. They just try to figure out how to do it. Sometimes it involves having the doctors or nurse practitioner or PA stick their head in the room for a minute or so and just be a consultant on the visit, and then hopefully it would be legal to charge for that visit. Practices have to be very careful to make sure that they do things in a way that's legal and goes by all the guidelines and rules about payment. No one wants to get into trouble. But until we have payment reform which doesn't only pay for visits to nurse practitioners, physician assistants, or doctors, until we have that, we're never going to be able to share the care as widely as we should do. But a number of clinics have been doing it even without payment reform. So this is the last homework assignment, which is, remember we did the share the care, who's doing it now? How about share the care, who should do it? So in your clinic, who do you think should be ordering mammograms for healthy women between 50 and 75 years of age? And then trying to figure out a workflow and standing orders, which you have to have to empower them legally to do it, figuring out a way to make that happen. So these are the building blocks of high-performing primary care. We've talked about probably the most important building block, which is team-based care. And hopefully every clinic over the next several years is going to be able to create teams with a proper structure, with standing orders, with sharing the care, increasing their capacity so they can see more patients, and moving into the 21st century of good primary care. I am done. If anyone has any questions, please ask them.
Tom, this is Jenny. I do. A couple of questions. One, what's the level of consciousness or awareness among clinic administrators in community health centers in our state where these decisions ultimately need to be made or supported? Is CPCA doing anything to advocate for these principles of team-based care?
I'm sure CPCA does. I haven't been in touch with them that recently. I think a lot of community health center executive directors are aware of this. Whether they're exactly aware of it the way that I talk about it, I'm not sure. I think the problem is that making it happen, because they're so focused on keeping their clinic financially stable, that even though they may want to do something, they haven't quite figured out, how am I going to do this given the current payment structure? So if you wanted to make a list of barriers to getting this to happen in community health centers in California, I think number one barrier is payment reform. I think a number two barrier is having enough people on your team to really do all this work. Because a two-person teamlet can do a certain amount of this but can't do all of it. You really need to have two support personnel for every clinician to really share the care and have other people adding capacity and contributing to the care of their patients. So the high-performing clinics we visited all pretty much had 2-to-1 ratio. So they might have, say, a teamlet, which is a clinician and a medical assistant, and around 3 teamlets, they'd have a nurse and a behavioral health professional and a health coach. So if you add that up, it's 2 support personnel for every clinician. Without 2 support personnel for every clinician, I don't think you can do a lot of this. And one of the reasons that a lot of clinics don't have 2 support personnel for every clinician is that back to the payment problem. So though I think administrators of clinics are very varied in their understanding of this kind of stuff, I think that if you got payment reform, a lot of them would want to move very quickly in this direction. So I think that's the main barrier. Then, of course, the other barriers are doctors being confident that they can share the care without reducing the quality of care for their patients. And some doctors just are difficult, and they don't want to give anything up. Even though they may complain, I have too much work, and you say, well, I could take some of this work away and give it to someone else, and they'll say, no, only I can do it. But other doctors are skeptical of giving up their responsibility because they're not sure that the other person who could take that responsibility is, number one, well-trained, number two, has time to do it, number three, is accountable to make sure that they are really doing it well. So those are some good reasons for doctors not wanting to give up some of these responsibilities, and then there are also some bad reasons which have to do with just only I can do it. So that's another barrier is doctors. And having enough time for people to get trained and mentored and making sure that the quality is really high, because we do not want to share the care if the quality goes down. The idea is to have the quality go up and to increase capacity at the same time. So there are a lot of barriers, but I think I'd put payment as number one.
And what about scope of practice? I can see that on the task list that you have, and you have a really good medical assistant, there are a number of things that person could be trained to do. I've always believed anybody can be trained to do anything.
Right.
But what issues about scope of practice come up with expanding medical assistant scope of practice here that are important to be aware of?
So Catherine Dower at the Center for the Health Professions at UCSF just did a wonderful summary of medical assistant scope of practice in California. And if anyone wants to email me, I can send it to you. She's a lawyer and an expert on health workforce. What turns out, and I've talked to her about this because some of it is a little bit confusing about what really is in the MA scope of practice and what's not. She feels that the scope of practice allows the MAs to do all of these things as long as the physician writes standing orders to empower the MA to do it. So she doesn't feel like it's a problem. What tends to happen is that, okay, there is some limitation in the scope of practice. I mean, we do know that MAs are not allowed to make any kind of assessments, diagnosis, any of that. That's absolutely necessary. But none of these panel management or health coaching things do that. What happens is that a lot of organizations use scope of practice as an excuse to not do something. So let me give you an example. At San Francisco General, where I work, medical assistants do all the immunizations. In fact, they don't even ask the doctors. They have standing orders to give immunizations to kids and adults based on the national immunization schedules. And they just give them. They don't even ask permission. They just do it. There's standing orders for them to do it. At UCSF Health System, the medical assistants can't even give shots. Not even a vitamin B12 shot or a flu shot.
Wow.
And that's because that's how they've interpreted scope of practice.
Mm-hmm.
I know a lot of people at UCSF are like, this is ridiculous, we have to change this. But this is two different fairly large health systems in San Francisco who have totally differently defined what the scope of practice for MAs is. So sometimes it's not the actual scope of practice laws and regulations, it's how the institution has defined them. So it's a complicated issue, but I'd be happy to send Catherine's analysis of MA scope of practice if anyone wants to send me an email.
Dr. Bodenheimer, this is Tundra from San Diego. I actually, thank you for your presentation. I was curious if you had read the same article in the New York Times in December, an article that goes through much of what you're talking about, does a nice job to summarize it. The title is When the Doctor is Not Needed. Have you read that?
Yes, I did.
Okay, and I was curious about your
Good.
opinion of that, and I think it would be wonderful to share with the group. It does a nice job of, while it doesn't bring up the team approach that you've just shared, it really outlines nicely what people are thinking and sort of where they're going with this concept.
I appreciate your making a note of that. I have it somewhere on my computer, but
I
how long
actually
it will take
sent
me
the
to...
link. No, I just sent the link to you, and Trish could post it, post the article
That'd be
if you're
great.
okay with that.
Okay.
That'd be great. Thank you for suggesting that, Kendra.
Yeah.
So we're coming up to about 3 minutes to 1, so if there's more questions, I'm here for 3 more minutes. Otherwise, it's been a pleasure to...
Trish, it didn't come up.
I just copied and pasted what you had sent to me.
Could you send it again, Kendra?
I sent her the link, so I'm not sure why it came in that format.
The other thing is that that we have a whole monograph which is on the California Healthcare Foundation website, which is called the Building Blocks of High Performing Primary Care, and it might be very worth people reading that because it gives lots and lots of examples from high-performing clinics of doing these things, especially related to team-based care. So it's
Great.
by myself and Rachel Willard, Willard, California Healthcare Foundation website. Just go to the website and you could type in Bodenheimer or Willard and you'll get it.
Great.
But lots and lots of examples from these high-performing clinics.
Tom, if you want to provide your email, I know you had mentioned if a couple people, were interested in getting some information from you. If
Sure.
you want to go ahead and present your email.
Should I?
You can go ahead and, I guess, just say it.
So it's T Bodenheimer, Bodenheimer, at FCM, that's Family Community Medicine, .ucsf.edu. Virginia, you have your hand up, right?
Oh, I did before with my 2 questions.
All right.
Click on it again, Virginia.
Okay. There.
It's down.
I'm down. Okay.
I don't know what it's really doing, but it looks like it's down from here.
Yeah.
Well, thanks, everybody.
Thank you so much.
Thank you.
Just
Thank you.
excellent and informative.
Thank you.
Great. Thank you.
Hi, everyone.
Bye-bye.
You have virtual waiting time.